Hi everyone, this is Mr. Neil Writer, also known as the Wax Whisperer. Thank you for tuning into this latest video. So for a patient who attended with bilateral otitis externa. So otitis externa is an umbrella term given for an infection and or inflammation of the outer ear canal and the outermost membrane of the eardrum. So the eardrum is composed of 3 membranes. The patient has to attend quite regularly, I would say every 5 to 6 months. And the issue with the patient's ear canal is that as the skin dies on the ear canal and also the outermost layer of the eardrum, because the outermost layer of the eardrum is composed of the same skin that lines the inner 2/3 of the ear canal, whereas in most people this skin would naturally migrate sideways and out of this ear. In this particular patient, this skin doesn't, and it just remains attached to the ear canal and eardrum. And you can see here the skin has become really hard and crusted. Now, you can be forgiven to believe that this skin has got some fungal infection because you can see some spores, but that's not the case. Now, the patient is regularly uses antibiotic spray. And what the antibiotic spray does, it almost crystallizes the skin, so it prevents it from getting infected and wet and sticky. Now, if you wait till the left ear, the second ear, unfortunately, the patient hadn't been using the spray in that ear, and it caused the skin to get infected and damp. So you'll see the contrast. So I'm just using the suction probe, just trying to lift this off the canal wall, and this crusted skin, it's adhered itself all the way around the patient's ear canal and also on the eardrum. So in a moment after I remove it, you'll see the shape of it. It's taking the shape of the patient's ear canal. And it is quite tricky because it's really hardened and crusted. And I'm going to revert to forceps in a moment. So what I'm trying to do is lift this dead skin off the canal wall, elevate it. So I've got something to grip onto with the forceps. If this is still on the canal wall, I can't really grip onto anything. Again, because we're on the bony part of the ear canal, we've got to be ever so gentle and cautious because we don't want to make contact with the bony part of the ear canal, because that can be very uncomfortable for the patient if we do. So I think I'm just going to go in with the forceps now. Even though it's still a bit tricky to get in the correct grip because this dead skin was oriented in such a way, it's hard to get over the skin on both sides. So each side of the jaws of the forceps is either side of the dead skin layer. They could be really, can you see the bottom jaw is close to the posterior canal wall there. So just raise it upwards, trying to go down. There's a bit of skin that's facing towards me there. Unfortunately, that time, the skin just shredded. It didn't come out in a big cast. So I'm just going back in, maneuvering the forceps forwards, from right to left, trying to move it away from the posterior canal wall. Just in the distance now, you can see it's strongly adhered to the eardrum. I'm just pulling the skin downwards now, from top to bottom, just to, again, loosen it off the ear canal. I believe this time I'm going to get a good grip, and I'm going to gently wiggle this skin forwards, left and right and forwards, so it comes off the eardrum and out of the ear. The patient has got quite a narrow ear canal. You can tell that by how much the forceps is taking up the internal space of the ear canal. The patient is unfortunately very still for me to do this. There's that little wiggle I was making reference to earlier, and you can see on the right it's detaching itself from the eardrum, and slowly but surely I've managed to remove this from the patient's ear. It was a very rough piece of dead skin. It was like some plastic. There's the patient's eardrum that's intact. Just some residual dead skin on the posterior canal wall here, and also the roof of the ear canal. So I'm just using a fine end gauge just to remove that. It's just block the tube. the skin is less crusted and a bit more stickier. I believe this is the last remaining piece of dead skin in the patient's right ear. So when I did the procedure, I actually did the right ear second. It was the left ear that I did first, but the left ear is a bit more, it's a bit longer, a bit more complex. I thought I would, when I upload the video, I'll show you the right ear first, followed by the second left ear. It's probably a bit more engrossing to watch. Now we come on to the patient's left ear. Now you can see here, the skin more immediately has become infected, damp and wet. The undercoat of skin is still quite, I wouldn't say it's crusted like the right, it's a bit more stickier, but it is a lot firmer than all this, the wet debris, this ear pus. And what I'm trying to do, I'm just trying to remove as much pus as I can. So it gives me some reference point to where I am in the ear canal. I'm just slowly going forwards towards the eardrum now. I can see on the right-hand side of the eardrum, the patient has got some granulation tissue. So there we are, the red bubbles. Granulation tissue, it not only occurs in the ear, it can occur in other parts of the body, but it occurs when your body is trying to heal from an infection or trauma. So in this case, the patient has got a natural infection of the eardrum because of the otitis externa. And what granulation tissue is, it's a buildup of connective tissue that then has its own blood supply. So you get a buildup of blood vessels within the connective tissue, and it gives it this bumpy red appearance, and it can be quite wet. Now, this is not the first time the patient has had granulation tissue. They have been seen by ENT in the past, and they have, I believe, attempted to cauterize this. So cauterizing is almost the burning of this connective tissue, and it kills all this connective tissue formation. And when it reheals again, we hope that the granulation tissue doesn't occur. However, it's not to be the case in this particular patient's case. So the plan of action really is just to clean the ear regularly, really. So the patient attends, I think, every 4 or 5 months. And we just have to keep on top of it. I think they left it a bit longer than usual on this occasion, and I did actually get some water in the ear. Now, water is really bad for the ear, guys, not only for this particular patient because of their chronic history of ear infections, but that's just for everyone, really. I always compare water in the ear to kryptonite, to Superman. It's the arch enemy. So do really, really avoid water being in the ear now. Just working very closely on the eardrum. The eardrum's still very damp and wet. We do have to be very, very gentle when we're working this close to the eardrum. The eardrum is very delicate. It's 0.1 millimeters in thickness. And when we work this close, invariably, the patient does move. The patient's not a scarecrow. They're not a robot. So there is little head movements. Even when you rest their head against the back of the couch, the chair, there is little movements there. So we have to be really, really gentle. And whenever I'm working this close to the eardrum, I'm always prepared to remove the instruments at a blink of an eye, just in case the patient makes a significant head movement, just to avoid causing trauma. So this is more damp, dead skin on the anterior canal wall. It's quite medial, but I was peeling it away more laterally. The umbo, so the centre part of the hammer bone. So the hammer bone is the first bone in the middle ear. The umbo is now visible. You can see it there in the middle of screen. It's almost like the bullseye of the eardrum. To the right, you've got the granulation tissue. So I'm just in the anterior recess here. So it's quite a tedious procedure. We're trying to remove layer upon layer of dead, wet, infected, dead skin of this patient's eardrum and also ear canal. And sometimes with dead skin like this, you just hover over the suction probe, over the eardrum, and this dead skin just comes out. But in this patient's case, it doesn't. We have to actually go through the process of peeling it. So getting the edge of the dead skin, finding that first, and then peeling it away. Because the patient has got a narrow ear canal, it sometimes can be difficult to manoeuvre the suction probe because there's limited space once we're in the ear. The patient has also got a very prominent inferior recess. So most people's ear canals, they incline upwards around 30 degrees. So we've got an upward slope, and then about 0.5 centimetre away from the eardrum, the ear canal narrows and it protrudes back out again. And that creates two trenches, two recesses, an inferior recess, a basin near the eardrum, and also one anteriorly, so to the front part of the eardrum, so in this case on the left-hand side of the ear. So I'll just come back to that in a moment. So again, there's some sticky wet skin should I say, on the anterior canal wall. I'm just removing that. And in the inferior recess, you can often, it's almost like a hideaway. It's a trench, as I mentioned before. It's very hard to visualise inside that. You can probably see that at the moment where we are now. The ear canal suddenly drops where the skin is, it goes down. And you can get a substantial buildup of dead skin. In a minute, you will see me remove a huge amount of dead skin. And it'll be very surprising when you see it, because you'll be wondering how on earth, where did all this skin come from? Because it's not visible to the naked eye until we peel it out of the inferior recess. So again, just going to mop up near the entrance, just some more keratin there, dead skin. It's a bit stickier. On several occasions, my fine end got blocked, so I had to unblock it. I think I used 2 or 3 fine ends in total, because on a couple of occasions it just got so blocked that I had to discard it and get another one. So again, this damp layer of dead skin. It's like an onion. It's going to peel it away. So obviously it goes without saying, you need a really, really steady hand when you're doing this kind of work so close to the eardrum. And a lot of experience, doing this for many, many years now. I'm a lot more confident, experienced, skilled in what I do. Anyone starting off, when we train our clear wax delegates, we're giving them realistic expectations, and it could take years before they can perform procedures like this, if at all. So it's not easy what we do, especially when the patient's awake. There's no anaesthetic that we use. Again, we're just on the anterior part of the eardrum because it's a bit damp there. You can see all that granulation tissue to the right, to the back part of the eardrum. You just see here the view we're getting. It's a really magnified, zoomed in view. And although it's zoomed in, we can still see the whole eardrum in one shot. Again, just placing the suction probe onto the eardrum, trying to peel the skin downwards. Now, all the work I'm doing now, it's more preventative. I'm just trying to delay and extend, should I say, the time period whereby the patient would need to return. What I'm doing now is not necessarily going to improve the patient's hearing. The patient can hear as well as they are going to be able to hear. I've removed the blockage, the sound can travel through, it can hit the eardrum. But this skin is not going to migrate. It hasn't for years, so because it's chronic. So we know sooner or later this skin is either going to get infected or crusted again. So I'm just trying to remove as much as I can. So even if it means the patient having to return in 6 months as opposed to 5 months, it's a month whereby the patient is symptom free. So we just come back out near the entrance again on the posterior canal wall. I'm just using a full Zollner suction probe here, trying to elevate the skin. You can see I'm going to peel it all the way towards the patient's eardrum. It's this skin that I'm peeling now. I'm going to use a fine end. When I remove it, you'll be quite surprised. I was referring to this earlier. So this skin, it's the ear canal goes up and the skin, then the ear canal goes down. This skin's lining the ear canal and it suddenly drops down in this trench. And I managed to gently peel it. And again, we're just going to be so careful. Don't want to touch the bony part of the ear canal. If I do, it's going to be really uncomfortable for the patient. It's one thing getting access, but then it's another thing removing it. We have to manoeuvre the suction probe to loosen it off the canal wall. And again, it's so difficult here in the inferior recess, and there's limited space. The patient has got quite a narrow ear canal. Unless we manage to peel this upwards. There we are. And I bet you weren't expecting that when I was peeling it slowly away. Neither was I. Again, just put the fine end gauge back on. I'm just going to try to peel some of the skin. The skin's less crusted, it's more stickier and gooier. Remember the right ear, it's a lot more solid. Just peeling this forwards all the way to immediately towards the eardrum again. So slowly you can see what we've done, layer by layer. We're removing this dead skin, and we're going to see the flesh of the ear canal now. So again, just at the roof of the ear canal. The skin that I'm now is still on the eardrum. So I've just reattached the fine end gauge. We're going to approach the skin on the roof of the ear canal, and we're going to peel it downwards off the eardrum, hopefully as much as we can anyway. Now sometimes the skin it's half dead, it's semi shedding, so it's dying but it's not yet dead, and it still therefore has strong adhesions to the eardrum, so it's just not quite ready, and we have to accept that. We don't continue. And whilst we're doing this, we're going to just make sure we don't cut into the ear canals. By cutting into the ear canal, if we abrase it, the patient's likely to develop a secondary infection because the canal is exposed, the mid part of the canal, the deeper part of the ear canal is exposed. So this skin, it acts like a protective layer. So we don't want to get through the fresh layer of skin that's not yet dead and it's still there lining the ear canal. So if we cut this or abrase it, it'll allow bacteria to enter deep into the ear canal, causing a secondary infection. And when we're on the outer part of the ear canal, the cartilaginous, the thin's a lot thicker, so we can put a bit more pressure on there. It's less sensitive for the patient when we do. You can just see the ear canal, how it goes upwards, the inclination. It goes up, then it goes down, so it's almost like a ski slope. It goes up and then suddenly down. Just some more skin that we're peeling gently. So it's quite a lengthy procedure, but again, I think it was time well spent. The drier we can get this ear, the more dead skin we can remove. The longer it will take before the patient has to return to have the procedure performed again. And hopefully the simpler it will be next time as well. It won't be as complex, because today is pretty complex. There's a lot of peeling, removing stuff off the eardrum, multiple layers of dead infected skin. It's got some dead skin, I think, at the top there. I'm going to try and peel that, I reckon. Yep, there we go. So it's going to bring this downwards. And I said it's not possible to remove all of it, but as much as I can, safely as possible, I will. Just loosened it, I think, a bit. Imagine peeling a stamp off an envelope. it's similar to that, but obviously we're on an eardrum, so someone's eardrum there at risk if we make a false move, so we're going to be really gentle. So as I get a suction grip, I want to pull the sucker away from the eardrum to peel this. Just on the hammer bone there, so reveal some of the hammer bone. Just wipe the lens, sorry, I didn't edit that out. So again, we've got a really zoomed in view of the eardrum, great magnification on the anterior part. I'm just trying to peel the skin away from the eardrum now, from left to right. This part of the eardrum is still slightly damp, so I'm going to hover the fine end directly onto the eardrum just to suction any moisture off it. Look at that view, you can see the whole eardrum there in one view. That's the benefit of an endoscope. That's the field of view it provides. So the patient has got a lot of scar tissue on the eardrum, which is non-surprising really, because the left ear is the worst of the two, and they are prone. Obviously, they do suffer from chronic ear infections, which over time cause trauma to the eardrum, and you get calcification, so calcium deposits building up on the middle membrane, where the connective tissue and fibrous layer is, and that gives it the white appearance. And we call that tympanosclerosis. In the extreme cases, tympanosclerosis can stiffen the eardrum so it doesn't vibrate. Quite often when I've got patients with tympanosclerosis, you do a hearing test and it doesn't really affect them as much as you think it would. Yeah, it's just on this, there's a bit of dampness there on the eardrum. So patients aware, got to be really, really careful to avoid water entering the ear. So I think that's the procedure done. I hope you enjoyed that video, guys, and you learnt loads. Take care, bye.